our global health keynote speaker for today, Her Excellency Dr. Zainab Shinkafi-Bagudu. And they're so excited, I didn't even continue. I call her a dear friend, and she's also a very inspirational woman. She is the CEO of Medic8 Foundation, Cancer Foundation, and member of UICC, who will enlighten us with universal health coverage matters for individuals and society globally, and the unique contribution patient organizations like us can make towards this goal. Dr. Zainab, the floor is yours. Again.
Thank you so much. Thank you, Dr. Siswat. A very good afternoon to everybody in the audience. It's like I'm at home. It's my first meeting, but I see so many familiar faces, many friends, some that I haven't seen in a while, and I love the atmosphere. So a big round of applause for everybody that is there and for all the good work that you're doing. Now, I know it's after lunch, and you've all had a nice lunch, but I think we will still be able to get through my slides in the allotted time, I promise. So like 4 years ago, we couldn't all sit in this room, could we? We were hit, the whole world was hit by a sudden, unexpected, catastrophic pandemic known as the coronavirus. And that stopped us from achieving a lot of things. We lost a lot of loved ones, but at the same time, it gave us hope and it gave us the ability to do things better. We saw a remarkable event. The whole world came together in no time, put resources, financial, technological, human resources together to create a life-saving vaccine that was distributed. What did we do? We created a universal cover for everyone at the same time. And simply put, that is what universal health coverage is about. It's about trying to access equitable care at an affordable price for everyone without disparity. Now, I come from Nigeria, which is the most populous Black nation on earth. It has a population of 260 million people. Like I said, we have issues around universal health coverage, but I want to share with you my own personal journey and relate it to what you as patient organizations are going through and how you can make it better. The Medic8 Cancer Foundation was born out of my vision or my observation that patients need help. It was initially a business, that is the Medic8 Diagnostic Center, but we started seeing a lot of people that were asking questions that needed help. I'm not talking about financial help, not just yet. They needed navigation, they had problems with their lumps in their breasts or somewhere else, and what to do about it. So we started a foundation that could support these kind of patients. And within that foundation, the layers started to unfold. The Cancer Society nationally. Eventually, we had a cancer research agency. The First Ladies, which is another cap that I wear. As the spouse of a governor, we have an organization known as the First Ladies Against Cancer. And I chair that organization now, and it's an organization that pulls together the spouses of governors of the states of Nigeria so that they can help patients within their states in different ways with information, with resources, and with policy advocacy. Those are the things that FLAC does. Naturally, we started to work globally with the UICC. I was elected in Malaysia. Thank you for those that voted for me. I see some of them here. And in 2018, and also working with the World Health Organization, it's almost impossible to work in health without working with the World Health Organization if you want to make any meaningful progress. So I know that patient organizations are doing some of that. And of course, partners, credible partners, helpful partners like Roche. Roche provides different types of access programs that help patients and patient organizations to find solutions to their problems. So by the time we had all this journey, there are often cited financial reasons for not achieving universal health coverage. But I've taken you through our journey and the things that we were able to do, not just in layers, but in reaching out to people and really focusing on what matters. Come to my local government, I need less than $2 million to save 100,000 lives every year from cervical cancer, breast cancer, diabetes, and this is a judgment call and a distribution issue. The funds that is available to us as a world, I'm not talking about of my local government, I'm not talking about Nigeria, I'm not talking about Africa, I'm talking about the entirety of the world. The funds are available, but the distribution is not equal. And that inequity depends on a judgment call that is made between the various layers of the world. So we have issues, no doubt, around assessing or attaining. WHO recommends an 18% expenditure for out-of-pocket expenses for health. In Nigeria, it is 70%. In countries like the UK, which has a good health system and insurance system, it's 13%. In the United States of America, it's about 19%, which is still above the WHO recommendation. So it means that if we're spending 70% or we're spending up to 70% of our health requirements out of pocket in Nigeria, it means we have the resources. It means there are some resources available to us. And if we were to further subsidize or putting more funding there, then we might be able to get better health outcomes. So the funding and the basic seed that is needed is available. But again, we're just not getting it at the right place. Instead, we find sometimes, investments in places that really do not have an impact. Last year, I was at the UN high-level meeting on universal health coverage. And one after the other, health ministers came on stage saying the same thing: resources, resources, resources. I'm not saying that resource is not an issue, but I know for a fact, and we have seen it demonstrated in so many occasions, that it's a distribution issue. And how are we going to, what are the things that we can do? This slide talks about the impact in low resource settings. I can stand here all day telling you about the impacts. Is it the mother that dies and leaves behind 6 children, who is already a widow herself from HIV? Or is it the children that have diseases that are not diagnosed until it gets to a terminal stage? There's so many examples. But we're winning with the partnerships that we're building and the ability that we have to talk to various populations across the country. The key thing for us in low-resource settings is education. There is a need to exchange more education. And the vital people that matter in this journey are the patient organizations. Of course, when the COVID vaccine came out, like a lot of other countries and like a lot of vaccines, there was a kickback. And what we did was to engage the civil society at the grassroots, and they were able to reach out to the places where they work. We don't stay in the state capital and just tell people to take the vaccine. They won't do it. You have to engage the community gatekeepers. They themselves have their own organizations, and they are able to talk to the people. And of course, the other key thing are patient organizations like yourselves here. Patient organizations bridge that gap between the policymakers and the needs that the patients themselves have. So there are some recommendations that we can do to get there. Focus on preventive care is a very low-hanging fruit for us. And education, education, education. I cannot say this more than, it's just the bane. There's so many patients that with a little bit of better awareness and understanding, we will be able to get the outcomes that we need. To address the social determinants of health, such as poverty, sanitation, again, education, and the health outcomes, we need to integrate this into our strategies for achieving UHC. The health workforce is an issue for us now in the LMICs. A lot of professionals, the few that we have, are migrating to higher income countries where there is more resources and the standard of life that they live is much higher. And of course, the remuneration is better. Sometimes it's not just about remuneration, it's about things like having adequate health insurance, like having adequate security, and having good schools for their children to attend. So these, I can see that we're starting to take a more responsible approach to this. There are some countries that are now limiting that flight, and this will help preserve the health forces. People argue about migration, whether it should be regulated or not, but the rate at which we're going, we're not going to be able to achieve what we need. Another aspect of UHC that is often not considered is the giving that happens in a community. Like I said earlier, in Africa, most people from Africa here will understand, or even low middle income countries, it is very, very difficult for a person to be ill and the community doesn't rise. It doesn't have to be the entire village or the entire state. It could be just your neighbors. They will come with an egg, with a chicken, with the equivalent of maybe 50 pence to help you get through that illness. It might not be what they need, but that spirit of altruism is there. And we're not tapping into those resources. There are different layers that exist that we need to look at in detail for us to be able to achieve the ultimate universal health coverage that we need. And this is one of them. There are a lot of credible organizations, foundations, again, from industry, from civil society, patient organizations, that are doing this kind of support. And unfortunately, that is not captured as part of the health coverage that we need, or part of the resources that countries have. And maybe if we do some more of that, or we capture it, then we will be able to get there more. This is a paper that we published with Chatham House in 2021, and it just shows the index and how, amongst other things, I picked this one because it showed how the countries were faring and the fact that we haven't moved much towards, and it focuses on cancer, we haven't moved much since then. So partnerships, I spoke about partnerships to improve access. I want to tell you a little bit about the PACE program that we have. It's a program that Rebecca spoke about, the national one. What she didn't tell you is that there are different layers of that type of partnership. Again, all trying to achieve access equitably to everybody so that the health outcomes can be better. And this is a form of universal, or a step towards achieving universal health coverage. What is the PACE program? It's a program whereby we enter into partnerships with pharma, such as Roche. They give us access prices that are just for non-profits. And part of the agreement is that we have to further subsidize the cost of the drugs. When we subsidize them, then the patients can access them. There's a national one. Some states have this type of arrangement as well. Nigeria is a federation with 36 states, so some of the states have that. And in our state, it is totally free when it was running. Right now it has stopped, but we're hopeful that it will resume again very soon. But the drugs that the patients access are free all through. And I know that Zambia had something like that, and that was the national one. So this is another layer, and then you come down to the foundation level, another layer, all trying to increase access and how the patients get their drugs. So I want to end by saying that as we leave this room, let us think that universal health is not a resource problem. It is not an elitist privilege. It is a fundamental human right that the resources are available for, that the world can afford if only we come together and put our resources in the right way, make the right judgments, and do an equitable distribution of the resources available to us. And who is going to do that? It is you and you and you in this room. You must make your voice matter. You must be advocates, you must be activists, you must do everything that you can to take the message to those who matter. I thank you very much for listening, and I hope that we'll get a chance to do some more later.
Thank you. Thank you, Dr. Zainab.